Psychotic and mood disorders. Schizophrenia is a psychotic disorder, and to qualify as schizophrenia, you need at least two or more of the following symptoms for at least 1 month: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. So the positive symptoms are the changes in thoughts and feelings that are added to the person's experiences, such as the delusions and hallucinations. Negative symptoms are the things that are taken away. For example, restricted emotions, difficulty in expressing pleasure, decreased thoughts and speech, and lack of energy. Other criteria include social and occupational dysfunction and work interpersonal relationships and self-care. Also disturbances for at least 6 months. Rule out schizoaffective disorder and mood disorders with psychotic features. Also rule out autism and substance abuse or other medical-related conditions. So the impacts on function include cognition, things like sequencing, planning, attention, problem solving, and memory. When you are experiencing hallucinations and delusions, your perception of reality will be distorted. And also occupational engagement, hard to participate when you're experiencing the positive and negative symptoms. Recovery is possible with effective interventions. Half the population can live independent, satisfying lives, and 25% require ongoing support to function. The other 25% have a poor prognosis with repeated hospitalizations and exacerbation of symptoms. Symptom management includes antipsychotic meds and a structured supportive environment. The OT interventions include medication education, coping skills, leisure activities, diagnosis, education, exercise programs, scheduling, routines, and structures for the ADLs, and identifying support system along with community mobility and vocational training. If you want to see more about the symptoms and deficits of schizophrenia, please click in the top right-hand corner. The three major mood disorders include major depressive disorder, bipolar 1 and 2. Major depressive disorder has the depressive episodes. So does bipolar 1 and 2, but bipolar 1 includes manic episodes. Then look at bipolar 2 and notice the difference that it has hypomanic episode. This is way different than bipolar 1. Other mood disorders include dysthymia, which is a mild form of depression, and then cyclothymic, which has emotional ups and downs and does not qualify for a depressive episode or a manic episode. Prognosis is very poor, but recovery is possible. Medication interventions based on recovery model promote satisfying lifestyles. Manic episodes in the diagnosis criteria are explained as elevated, expansive, or irritable moods lasting at least 1 week. And then 3 or more of the following: inflated self-esteem or grandiosity, decreased need for sleep, pressured speech, racing thoughts, flight of ideas, distractibility, psychomotor agitation, excessive involvement in pleasurable activities with high potential for painful consequences. So think about how this impacts function. If you lack inhibition, you're going to do a lot of impulsive things. And also that high energy level most people can't keep up with is going to lead to little sleep, you're going to stay up for days, and poor judgment. You're not going to make the best decisions. You're going to have problems with self-care, you're probably not going to want to shower, might have trouble with relationships, and irresponsible work performance. Symptom management includes antipsychotics, mood stabilizers, and OT interventions, limit setting to improve boundaries, provide structure and opportunities to release excess energy in positive therapeutic manner. Other interventions are symptom and medication management, problem-solving, coping strategies, expressive activities, social skills, daily routine, and vocational training. Click on the link in the top right-hand corner to see what the clinical picture of a manic episode looks like. Now, for major depressive episodes, you need to have a 2-week period of depressed mood or loss of interest in pleasure. 5 or more of the following symptoms are also included, such things like depressed mood most of the day, and diminished interest or pleasure, weight loss, gain, decreased appetite, insomnia or hypersomnia, psychomotor retardation, agitation, fatigue, loss of energy, feelings of worthlessness or guilt, diminished ability to concentrate and make decisions, and recurrent thoughts of death, suicide, with or without a plan, or a suicide attempt. In a depressive episode, you are anxious, a lot of fear-based behaviors. You have difficulties in social interactions, relationships, sexual functioning, self-destructive behaviors, including suicide and substance abuse, and may manifest in somatic complaint. Impacts on functioning include tearful brooding and isolative behaviors, which lead to lots of anxiety, concerns about physical health, and when you're that isolated and hopeless, you have a hard time participating in occupations. So how do we help? Antidepressants have shown to be very useful. The most effective combination is medication with psychotherapy. CBT is also great if they demonstrate self-awareness, intact cognition. ECT as a last resort has also been used. OT interventions include monitoring closely for self-destructive behaviors, provide a safe environment, diagnose and symptom education, medication education and management, coping strategies, expressive activities, social skills, daily routines, and vocational training. To see the clinical picture of a major depressive episode, please click in the top right-hand corner. And lastly, we have the mixed episode and hypomanic episode. The mixed episode meets both the criteria for manic and major depressive episodes for at least 1 week, and hypomanic episode, that's the bipolar 2. Symptoms are same for manic episodes but not severe enough and can last 4 days rather than 1 week.